Welcome. My name is Scott Hensley, and I'm Senior Health Editor at the NPR Science Desk. I'm also today's moderator for the panel. The world is approaching the second anniversary of a cluster of cases of respiratory illness tracked to a seafood market in Wuhan, China in December 2019. The cause, a virus we now know as SARS-CoV-2. The World Health Organization named the illness caused by the virus COVID-19 in February 2020. As cases mounted in China and began spreading elsewhere. Since the virus emerged, more than 5 million people have died from it, and more than 250 million have been infected. Where are we now in the COVID-19 pandemic, and where are we headed? Joining me today to discuss these topics are Kizzmekia Corbett, an assistant professor of immunology and infectious diseases at the Harvard T.H. Chan School of Public Health, Rick Maui, senior physician in medicine in the Division of Infectious Diseases at Boston Children's Hospital. Sorry for the technical issues there. Let's go ahead. Also joining me, us on the panel is Bill Hanage, Associate Professor of Epidemiology and Co-Director of the Center for Communicable Disease Dynamics at the Harvard T.H. Chan School of Public Health. And joining us today is Amir Moharab, infectious disease physician, Massachusetts General Hospital, and an instructor at Harvard Medical School. Amir conducts clinical and epidemiologic research in infectious diseases across Africa and the Middle East. Unfortunately, one of our panelists, Dr. Louise Ivers, had a death in her family, and so Amir has agreed to step in. We send our condolences to Dr. Ivers and her family, and thank you, Amir. I'd like to remind everyone that this event is part of the Dr. Lawrence H. and Roberta Cohn Forum Series. We are streaming live on the website of the forum. We're also streaming live on Facebook and YouTube and selected stations in the NPR network. Viewers can submit their questions. Via email to the forum at hsph.harvard.edu. Before we begin, let's watch a short news clip about the rollout of the Pfizer-BioNTech vaccine to kids between 5 and 11. This clip is shown courtesy of Reuters.
From the highly contagious Delta variant. For many, it couldn't come soon enough. Since the start of the pandemic, nearly 2 million kids in the U.S. under age 12 have been diagnosed with COVID, says pediatric emergency doctor Matthew Harris.
8,400 of them have been hospitalized. So there's an urgent need for vaccination.
The Pfizer vaccine is shown to be more than 90% effective at preventing symptomatic infection in children, bringing with it the hope of fewer quarantines or school closures and more normal activities and freedoms.
I think I'll feel maybe stronger now that I have the vaccine, and maybe I get to do more things.
That's a relief for New Jersey mom Jojo Doble, whose 2 young children have not seen their grandfather, who is immunocompromised, for 2 years.
It'll make life that much easier to be able to take the kids places, to not feel so worried about, do we have a mask, do we not have a mask? Can we be around these friends and their kids? Can we be around my parents? Can we be around our neighbors? And not all have to stand outside around a fire pit or with, several layers on now that it's getting cold.
Still, it remains unclear how many parents will jump at the chance. Even many who have been vaccinated themselves are more divided over whether to vaccinate their own younger children, given that severe COVID is much less common for them. Dr. Harris empathizes, but calls Pfizer's research impressive.
I am a parent of school-age children, of 7-year-old twins, and I recognize that this is a difficult choice for parents to make, but for me, the calculus is simple. This is the easiest way I can keep my kids safe.
California has mandated school-age children get vaccinated once their age group is eligible, a measure being considered in New York and Washington state.
Okay, Kizmiki, as we heard in that clip, many parents are eager to get their children vaccinated, but many others have questions and concerns, often around the process by which the vaccine was developed and tested. You've got firsthand experience in this process. What would you like the public to know about how these vaccines were developed and then authorized by the government for use?
Thanks a lot, and obviously thanks to Chan for inviting me to be a part of this forum. It is a delight, especially as we get these children vaccinated. One of the things that is important is just that keyword that you said, is that process, right? I think that parents, grandparents, and anyone else who is a guardian of a child need to understand that getting vaccines authorized and approved for any age group, whether it be adults, elderly people, and then now children, comes with a process that is highly vetted by the regulators at the Food and Drug Administration and comes with a lot of data, right? I hear parents saying, for example, that they were not convinced that enough children were having the vaccine tested on them, as there was only several thousand children having the vaccine tested, as opposed to tens of thousands of adults who had the vaccine tested. But these numbers actually come with a statistician's approval, right? And all of these things, each, whether it be the number of people that the vaccines are tested on, the doses of the vaccines that are given to the children versus adults, all of these little incremental details are tested and tried and true, and they must stand the test of time. So the other thing that parents, I want you all to remember, is that it's not just that first initial bit of data that informs this process, but the regulatory agencies continue to watch and monitor these vaccines as they roll out into your children. And so at any point, if in time that there is a red flag, you will know, and we will all know.
Rick, now that the FDA has authorized the Pfizer COVID-19 vaccine for kids between 5 and 11, how do you think that's going to change things for children and their families? What are you seeing, for instance?
Yeah, I mean, it's of course, many of us were thrilled to be able to now offer something to kids of that age. It's a huge accomplishment in a short period of time. I think it's important to remember that we think of COVID in its impact on adults in terms of what it did to so many adult patients. In children, as I think the audience knows, the real biggest problem was the collateral damage, the psychiatric illnesses that we're seeing that have emerged or have worsened, the closures of schools, the economic and financial insecurities. And in some sense, the vaccine can help contribute to improve all that by sort of reducing the anxiety that many of these families are feeling over the state of COVID. I think in terms of what we see now in families, there's really three groups. There are individuals the parents have been vaccinated and they can't wait for the kids to get vaccinated. That's a large group of people. A second group are individuals where you have parents who've been vaccinated, but they still have a fair amount of uncertainty or hesitancy towards vaccinating their kids, and they want more information, more discussion with their primary care providers or healthcare providers. The third group are individuals who themselves have not wanted to be vaccinated. And as you can imagine, that group is very reluctant also to see their kids be vaccinated. I think that in our attempt to talk to parents and to try to educate and reassure, it's obviously very much easier to imagine convincing the second group than the third, although of course effort should be made on all three groups.
Thanks, Rick. Appreciate that. Bill, where are we right now, as far as the pandemic goes and the sort of dynamics of the disease? We've seen so much changing and sometimes unexpectedly so. Do you think that vaccinating kids, for instance, will have a broader impact? And where do you see the pandemic heading?
Well, I'd echo everything that Rick just said. I think that it's going to be really valuable in terms of helping people be more confident and comfortable with their kids going to school, and it's going to lead to less disruption. But we have to, let's keep it real. The things which are the real headline impacts of the pandemic depend on the proportion of older people who have been vaccinated. And you can really see that in what's been playing out over the last few months. Florida, which had a pretty poor vaccination rate in its older over 65 population, had around a third of its pandemic deaths since May of this year. In other words, since vaccines have been available. If you look at Europe now, you can see that there are pretty high case counts across places like France, Germany, and the UK. And while these are having non-trivial impacts, they are much, much less so when it comes to the headlines of deaths and hospitalizations than, for instance, Romania, which has a relatively low vaccination rate, about 30% of its adult population fully vaccinated. So looking into the winter and the uncertainty that, well, we do have the certainty that the virus is going to pick up steam a little bit with seasonality. We can be ready to see that the places which have got fewer of their older population vaccinated, the grandparents of those kids who are getting the shots now, they need to be protected. And I think there's still the capacity for some pretty nasty stuff if we don't keep our eyes on that prize.
Thank you. Thank you very much, Bill. Let's turn to Amir about what's happening beyond the United States and even the developed world that Bill mentioned. We know that in many places, the vaccination rates are in the low single digits. What needs to happen to change that? What needs to happen to make vaccines more widely available?
Well, thank you for having me, and thank you for asking that question. In most parts of the world, vaccines are not being distributed because they are not available. The more than 7 billion doses of COVID vaccines that have been administered so far are concentrated in high-income countries. So, for example, less than 6% of people in Africa, the entire continent, have been vaccinated. For many of us who do work overseas, our colleagues who are healthcare workers, who are also in the same places that don't have access to personal protective equipment, PPE, the same places that don't have access to testing, same places that don't have access to oxygen and other life-saving treatments, are the same places that also don't have access to vaccines. And then for many others of us, it's our family members overseas who don't have access to these vaccines. And so this is why this pandemic and the horror of this tragedy is going to continue. The IMF estimates that we may have 5 million more deaths in the next few years, trillions of dollars or more of economic losses. And that's easy to forget if you live in a city like where I live in Boston, where with every cinema that opens up and every bar that opens up and every restaurant that opens up and every kid who's able to go back to school, and these are great achievements that we've made, we have an inequity, we have an apartheid system that is baked into our healthcare system that prevents these life-saving technologies getting to people around the world. And so what needs to happen is for excess vaccine supplies and stockpiles of supplies that have been surplus and stockpiled in rich countries to be donated immediately. Vaccine manufacturing capacities need to be increased overseas, and that involves sharing the recipe of publicly funded technologies that have been made. And we need to build up health systems beyond vaccine technologies to other life-saving treatments as well.
Well, thanks everybody for your insights. We're going to dig into some of these in a little bit more detail. Before we move into that portion of our program, I'd like to remind everybody that this is the forum at the Harvard T.H. Chan School of Public Health, and today's event is being presented jointly with NPR. Viewers can post their questions to the forum at hsph.harvard.edu. Before we go into the next part of our discussion, let's watch a short clip about the impact of COVID-19 vaccination in India. This clip is shown courtesy of Gavi.
मेरा नाम मोहम्मद सरवर खान है। मेरे साथ तो बहुत बड़ी ट्रेजेडी हुई थी। जब कोविड का आया था सिचुएशन, तो उस समय मैं बिल्कुल घर गया हुआ था। मतलब मेरा घर बिहार है, मैं वहाँ गया था फ्लाइट से। तो उस समय कुछ भी इम्पैक्ट नहीं था। जैसे ही मोदी जी ने हमें गाइडलाइन दी कि भाई अब सबसे पहले जनता कर्फ्यू लगने वाला है, आई एम ओके विद दैट। देन जब मेरी रिटर्निंग की फ़्लाइट थी, उसी समय आ गया कि अब टोटली लॉकडाउन हो रहा है। तो मैं अपने घर पे ही फंस गया। मतलब 2-2.5 महीने तक मैं ड्यूटी पर नहीं आ सका। लेकिन सोसाइटी की बात करें तो सोसाइटी से बहुत ही इम्पैक्ट हुई थी इसमें। अब गरीबों की बात करें, उनका जो डेली वेजर्स हैं, उनके पास तो कोई जॉब नहीं थी। और जो भी जैसे कि बहुत सारी जॉब चली गई थी उसमें बहुत लोगों की, तो वो इम्पैक्ट हुआ था इस पर। और इवन मैं जब अपने बिहार में था तो इसके रिगार्डिंग बहुत सारी अवेयरनेस कैंप भी चलाई थी मैंने। इवन जो गरीब थे उनको मैंने फूड प्रोवाइड किया था। हमें तो बहुत अच्छी फीलिंग हुई थी कि चलो भाई, वैक्सीन आने से ये तो है कि जो लॉकडाउन है वो ख़त्म हो जाएगा और जो भी रोज़गार है वो शुरू हो जाएंगे, जो भी गरीब हैं उनको जॉब मिलेगी। इवन भरोसा करना भी चाहिए क्योंकि ओवरऑल ये हमारी कंट्री के लिए सोच रहे हैं और मैनकाइंड के लिए सोच रहे हैं। तो दो डोज मैंने लगवा ली, तो अब मैं अपने आप को ये बोलूँगा कि मैं स्ट्रांग हूँ। और इवन मैं अपने अंदर पॉजिटिव एनर्जी ये उजागर करूँगा कि नाउ आई एम फाइटर एंड विल फाइट विद द कोविड।
In that clip, we heard what sounded like a real success story. What will it take to make vaccination broadly accessible to the rest of the world? Is India unique, or are there other steps that we could take to keep people safer? Amir, do you have some thoughts on how that might unfold or happen?
You know, I think a lot of us watched in horror when for some of us, our friends and family, for others, just stories in the news last spring as India had a devastating wave of COVID that overwhelmed their healthcare infrastructure. And so I think it is a big achievement that they've been able to increase vaccine manufacturing capacity so much, distribute so much of the vaccine to many parts of the country. There are certainly lots of parts of India that are still at risk and still don't have access to testing and such. But what this tells me is that these kinds of scarcities in healthcare resources are a decision. They are a choice that we make as a global and public health community. We are making these policy decisions that concentrate resources in some parts of the world and not in others. And we would wonder what our low and middle income countries and what our healthcare workforce in these places look like if we decide to more equitably distribute some of these resources. So I think it would take a massive increase in manufacturing distribution like we saw in India, donations of what are now just stored and stockpiled surplus vaccines in many high-income countries that are waiting for the next booster to be approved or the next demographic to be approved for another dose. And then increasing the manufacturing capabilities or the health systems capabilities, not just for vaccines, but also for testing and other resources as well.
Amir, I think you bring up a couple of great points there. I mean, India has a unique capacity, or maybe if not unique, a very well-developed capacity to manufacture vaccines, which is not a simple endeavor. Kazmiki, could you help us understand a little bit about what it takes to make a vaccine at scale and why that is a challenge?
Scaling up a vaccine takes so many small pieces that it's very hard to really put it into one bracket. But the truth of the matter is that we all talk about this recipe or so-called secret sauce, but just as we think about recipes that, for example, we might get from our grandmother, there comes with it the skill. What a dash of salt might mean to me might mean a little bit different than what it means to my grandmother. And then there is the oven, And there are all of these little things. And so if we think about vaccine technologies and the transfer of those technologies in that way, we really start to understand how mass and huge that effort must be, especially to get vaccine manufacturing capabilities all across to every corner of this globe. And so, as was said before, there are other things that could be done to kind of fill in as the systems and the manufacturing capacities come on board, such as donations of vaccines and et cetera. But I like to call for a moment of grace here, because there is so much, right? There, even on a company to company level, you see differences in manufacturing, and also on a technology to technology level, right? Novavax has a different type of manufacturing than, for example, Pfizer might have, and really teaching all of those small pieces within each vaccine technology to every single place that might be able to make the vaccine could be quite tricky. And I think that we're really going to have to, number one, have grace, but then secondly, really peel apart the different layers of what it really means to share a recipe and dive into the processes and be deliberate about the actions within, whether it be sending the skill set and the labor to those places, whether it be actually funding and building the manufacturing capacity, on top of, as one might say, share the recipe.
Thanks very much for that. I understand it quite a bit better now. Rick, if we could turn to you, I think, here we are in this country offering booster shots and extending vaccines to very young people, children. And I'm wondering, what's your view on that at a time when other countries haven't been able to get even the first shots for the most at-risk people in their populations, and what it might take to kind of change that or fix that?
Yeah, it's a great question. I think there's really two ways to think about it. One of them is, what is the best way for us to get a better handle on the pandemic at home? A very self-centered view. Who should we really be focusing our efforts to get vaccinated? And it's almost certainly not kids. And it's probably not even boosters, honestly. It's probably focusing on people who have not yet had a first shot and who are at risk for serious disease. So looking at it from a sort of very self-centered, home-based view, you would say these are important advancements, but maybe not the ones that are really going to be game-changing. Then you sort of start looking at the world, and I think both Amir and the video that you showed sort of very poignantly instruct us on this, which is it could be viewed as ethically extremely challenging to start vaccinating 5-year-olds whose risks of severe disease or mortality from COVID are so low when the rest of the world has immunization rates in the single digits. I think the WHO Director General referred to it as a moral catastrophe when the US and Europe were talking about vaccinating kids while whole continents were not even getting vaccinated yet. So, I'm not trying to say that we shouldn't try to do everything, but some sort of prioritization would be very important. And while many have said that it's not because you will, not vaccinate kids in the US, that those vaccines will find their way in the developing world, I think many of us, in fact, I think all of us on this panel have said in some form or another that it is a matter of where the companies will focus their attention. If a company is told that there's a whole market of boosters and children and even younger than 5-year-olds that they need to take care of, then you could imagine that their focus will be on providing that rather than perhaps doing some of the other maneuvers that were just mentioned that would really be, I think, humanitarian and ultimately more life-saving.
Bill, could I ask you, kind of related to this, what your view is of boosters and sort of, when it makes sense and, what effect they may or may not have on the trajectory of the pandemic around the world?
Certainly. I would echo everything that Rick just said, and he said it very eloquently. I mean, to put it bluntly, you have to give a hell of a lot of boosters to somebody like me to have the same benefits in terms of preventing severe illness of getting just one shot into somebody over 65 who has not received one yet, wherever they are in the world. And while in parts of the United States, there are still issues with vaccine access, but of course, we've managed to get a lot of shots into a lot of people. But there are still some who are holding out. You know, a vaccine campaign is like climbing Everest. The first part is easy, and as you get closer towards the end of it, it's harder and harder because you're trying to reach those parts which have not yet had the shot. But boosters are for older folks who are vulnerable to severe disease. I think that that's defensible and reasonable. But for younger people, the protection that is being gained there is not going to be a direct protection against severe illness. They're very unlikely to have severe illness if they've already been immunized. There may be a little bit of benefit, remains to be seen, in terms of perhaps preventing infections and ongoing dynamics of that. But if you want to take this as a global problem, then absolutely, these doses should be going to people who need them elsewhere, because infectious disease is something which teaches you that selfishness is a really, really short-sighted thing, because, you know, you might be looking out for yourself, but you need other people around you to be looking out for you if you are not going to get infected. And I wish that we had been able to learn a little bit more of that kind of perspective after 2 years of this.
Amir, I see you nodding here and wonder, you know, why, given our even recent history with other pandemics, has it been so difficult for this message to resonate this time around?
You know, it's true. I mean, we do not distribute essential medicines and essential supplies based on human dignity or need, or we distribute it based on money. Even though a lot of these technologies, and particularly in the case of the COVID vaccine, the mRNA vaccine that was developed and researched with publicly funded taxpayer money by brilliant scientists like Kizmikia and others, we have a system where our National Institutes of Health funds this, researches it, and does it with the idea that these resources can be distributed around the world to treat and eliminate the scourge on our humanity, which is COVID is one of them. And one way that we can distribute it very effectively is to have a company or a pharmaceutical company kind of market it and take the rest of the process. But in this case, it has not worked. And we hear the same sort of things from a lot of these companies and manufacturers that we've heard during the HIV/AIDS epidemic. We hear that, well, you can't really share the recipe because it's too complicated for physicians overseas. It'll be too complicated for pharmaceutical companies overseas. But we get most of our generic drugs from international manufacturing companies. And we've learned that physicians in the most resource-poor areas are able to prescribe and treat complex infectious diseases as well as we do here. So I really do think that it comes to finances, and we have to press the issue over and over again to donate our surplus supplies and increase manufacturing capabilities for tests and vaccines and essential medicines.
Thanks very much. Well said. I was wondering if we could address a paradoxical problem, perhaps, on the other side, is that there are places where the vaccine is in ample supply, like here in this country, and yet we still face enormous hesitancy among some groups of people. And I'm wondering, you know, Rick and maybe Kizmikia could weigh in too. You know, what are your thoughts about how to deal with this rather persistent issue in some places where the vaccine's available, but people don't want it?
I'll start by saying that I like analogies, as one can tell, but, you know, the Mount Everest analogy really sticks with me, because the thing about vaccine hesitancy is that you get to almost the top of the mountain and then there becomes clouds and you then have a rip in your boots. And also, most importantly, when we think about it from the vaccine perspective, is the fatigue, right? The fatigue from the vaccine educators like myself and everyone on this call, from healthcare workers, and also people who were in the beginning really listening to our words and heeding what we had to say, but now they've driven off into their own way of thinking about these vaccines. And so really tapping into how to cover that last bit of basis is extremely hard when we think about vaccine hesitancy or inquisitiveness. And so I think that number one, we have to not give into that fatigue from our side. Otherwise, we were not going to be able to really handle the fight if we tire out and start to refocus our energy on the people who, for example, have already been vaccinated, or, as was mentioned in the beginning, when it comes to families and their children, to the families that are very open to getting their children vaccinated, right? I think that the way that I like to reframe it is this: each time there's something new that comes out with these vaccines, whether it be the boosters or whether it be children getting vaccinated, it is a new moment for us to read up, to and to really put on new boxing glove and stay in the fight and not tire out. You know, teaching about the booster reminds people, as have been said across this call several times, that really it is mostly important to just go and get your first and second shots. And teaching about, you know, children getting vaccinated reminds those families that really it is also very important for you as a parent, a grandparent, or guardian to also get your shots as well. And so reminding all of us what these teaching moments are, and then reigniting what was that initial energy across this country and beyond, actually in the globe, around thinking about these vaccines in a very different way than we thought about vaccines before. And so it really comes down to keeping the conversation open and not tiring out, and changing our boots when they have holes in them.
Rick, you got your boxing gloves on?
Yeah, I do. I mean, I agree. I think, you know, one thing I wanted to point out, Scott, is I really like the fact that not once during this last half hour have you or any of us mentioned the word anti-vaxxer. I just did. I apologize. But I do think the emphasis on vaccine hesitance or hesitancy is really absolutely critical, because one of the ways in which we lose the debate is when we start being disrespectful of the fact that some people have genuine concerns, whether they are founded in science or in gut feeling or in misinformation from different websites. We don't know. But it is a legitimate attitude that people have to be a little bit reluctant to accept something. That's just human nature. And I think the fact that we refer to these as hesitance rather than some pejorative term, I think is really very important. In that context, there have been some missteps, I think, in our communication to parents, to patients about the need for vaccines and what they do. And even as recently as the last couple months, when many of us were talking about when the vaccines would be available in children. This was before FDA or ACIP had even reviewed the documentation. We were talking about probably vaccines will be available end of October or before Thanksgiving. And I was even asked that question by several reporters, like, when do you think the vaccines will be available? And in fact, when we answer that question, we're sort of sending the message that this is preordained, that the process that Kizmikia was referring to, the very thorough process, is irrelevant, because we're already talking about getting kids vaccinated before they have their first bite of turkey. At the same time, we can try to address some of the hesitancy by a careful discussion with parents. That's what many of us do. Some of the questions that come up can be addressed scientifically with the data that we have, not just from these vaccines, but from other ones. My wife, for example, is a obstetrician gynecologist, and one of the most common questions people ask is, how do I know that this vaccine won't cause long-term fertility issues in my daughter? We can't obviously answer that question with any certainty, but we can point out that in general, vaccine-related side effects are much, much more visible in the short term. There's very few examples, in fact, none that we can think of vaccine that cause problems in the long term. And referring people to those types of data in a respectful way, referring to them as hesitant rather than anti-anything, I think is one way to try to broaden the dialogue and get people to understand what we know and what is unknown about the vaccines and help them make what we think is the right decision.
Well, before we move on to our next question, I just wondered, off of what Kizmikia said about fatigue, Is there a need for a new message or a new way of communicating on these topics, given the length of time that we've been trying some of the techniques that you tried, Rick? What is there time for a course correction or keep doing the same kind of thing?
I mean, I'll let others comment on this as well, but I agree with you, Scott. You sort of worry that we're sort of doing the same thing and hoping for a different result, and that obviously is something many of us are worried about. I think we do, to a certain extent, have time on our side, particularly as far as kids are concerned, because as I mentioned earlier, and as we all know, there are some parents who are very determined to get their kids vaccinated very soon, which means that in a short while, we will have millions of data points to talk to us about the safety of these vaccines, how well they're tolerated, what side effects we're seeing. And ultimately that will help when we start talking about the data and not just, a small clinical trial of 3,000 kids. When we start talking about millions of children being vaccinated, that will help. I think that's what's helping to a large extent, getting more and more people vaccinated. Another approach that has been used in France, for example, is to start tying vaccination in a sort of positive way to being able to go to restaurants or movie theaters or other areas. I think a lot of places are turning to that. While the French president lost initially a lot of votes when he made that decision, the truth is that while there were demonstrations and people getting very angry at him, France saw the largest spike in vaccinations that they had seen since the beginning of the pandemic, because there's one thing you just don't do is forbids Frenchmen from going to a restaurant. That's just not possible. And so those types of strategies, maybe in a less punitive way and more in an encouraging way, I think could be explored further in the US and in Europe. I'd
actually add to, other than saying that, yes, again, Rick, I agree with you. I think that it may be helpful to think in terms of vaccine confidence rather than hesitancy, because I think that it's important for us to remember that parents who are anxious about vaccinating their kids, they're good parents. They're thinking about their children. They want information. These are people who should be, they deserve our compassion, and we should be able to talk to them and listen to their concerns and try and, just assuage those concerns. The other thing I wanted to say is that, though it's not my area of research, I know there's a lot of work showing that trusted people within communities are where people are most likely to get information that they rely upon. So if you're listening to this and you happen to be in an under-vaccinated community and you're in a position of trust and authority, I encourage you to reach out and listen to people, try and understand what their reasons for not being vaccinated are, and try and help them come around, because you could be doing something which would really be life-saving.
I completely agree with that point. I actually, in my own neighborhood, had people walking around my neighborhood yesterday taking a vaccine survey. I loved it because it felt like people were checking in on their neighbors. And if that happened in just about every single neighborhood that we, around this country and even around the world, you would probably see an increase in vaccination, because it feels like your friend, as opposed to me or any of us on your computer screen or on your TV every day, really talking to you about the data points, which is essentially what is happening when we talk to people about the different things with vaccination, whether it be children or boosters or et cetera. And so I like that idea. I also like the idea of the reframing of the conversation from making it feel like people are missing something, and instead making it feel like we are missing something. Because if we haven't gotten our point across with all of the tireless efforts that we've done over the past 2 years even, then simply we are missing something maybe. And maybe it's time for us to kind of step back and reframe the conversation to a point where we are only listening. And so I am not a researcher in vaccine inquisitiveness / hesitancy at all, but one of my own strategies is to not say anything unless I'm asked, and really to present myself as, okay, at this point, I'm just here for whatever it is you specifically want me to answer around the questions that you have for the vaccine for yourself on a very individualized basis. And that may not be sustainable in the long term, But that is where we are 2 years into a pandemic and almost a year into the point where the first vaccines in this country were rolled out. You're muted, Scott.
Yeah, I hate that when that happens. All right. How's that? Thank you for the great discussion. I could hear it all. Anyway, you know, one of the questions that I hear a lot is, what about variants? You know, we've seen this, recent waves tied to Delta, and it seems, based on some of the things Tony Fauci has said, that you know, at least in this country, Delta is king. And I'm wondering, Bill, what your view is on what the future might hold for variants, and you know, what kinds of things are happening to determine which variant comes to the fore when?
Well, the most important thing for a virus is transmission. So one of the things that we have seen repeatedly over the pandemic is that it's, at this stage, up to now at least, it's been transmission which wins out. Alpha was more transmissible than what went before. Delta is even more transmissible than Alpha, and it looks like it's a bit nastier. It's more likely to end up putting people in a hospital. So at the moment in the UK, which has been doing absolutely incredibly detailed epidemiology of all the stuff that's going on there, despite the fact that they're having very huge case numbers, they've been dropping their weekly technical briefings or every other week, which details the variants which are present within the population. And you can see there, for instance, that so-called Delta Plus, which is, give it its technical name, AY 4.2, hopefully it'll be given a name soon, so I don't have to keep saying that, has been increasing, not rapidly, really quite slowly, but it emerged in around July, and it's now about 14% of cases, but it's consistently going up. And that looks like it's associated with about a 10% increased transmissibility over Delta. And, you know, that's, I mean, Delta's already a phenomenon. I mean, it's really quite remarkable. And so to have an additional 10% increased transmissibility means that we're likely to see a bit more of that. At the moment, remember, while the consequences of all this transmission are not trivial, they're nowhere near as grave as they would be in the absence of vaccination. And so I think that as we move forward, we're going to be seeing more things like Delta and perhaps more transmissible things too starting to circulate around the world. But the important thing to remember is that given the properties of Delta, it's not going to be terribly long before everybody has been either infected with Delta or vaccinated, or both. And that is going to mean that the virus is then going to be evolving, and it's going to keep evolving. You know, the only virus that doesn't mutate is a dead virus, and it's going to keep on evolving within that context. And I think that that's going to be something we're going to have to wait and see. We're going to be getting data early next year, I should think, on what we can expect for the longer term, because this is the transition to what folks call endemism. Because we'll be through the pandemic phase of the outbreak, and the virus will be just circulating in communities with consequences that at the moment we don't really know enough to say, but they're unlikely to be quite as grave as the initial surge of infections that we've just been living through. However, as I say, watch this space, things can change.
All right, we'll do that. I wanted to turn quickly to one other topic, and then we'll go to the questions that have been coming in. And that is, you know, we're in the position where fairly soon, it looks like there'll be at least 2 antiviral therapies or treatments available that are pills, as opposed to the antibody therapies, which are a little more difficult to administer. And I'm wondering, Amir, you know, what do you think the role of those kinds of treatments might be? And then, you know, will we see a replay of what happened with vaccines, where they're available in the richer countries and not so much in the developing world?
It's a really good question. And I'll say that it's a decision that has not yet been made. You know, it is our choice as a society and as a kind of a global health community, how to approach distribution of life-saving technologies. And so the pills, the oral antiviral therapies that are being developed are really impressive. The preliminary data are reportedly good. We still have to kind of analyze them, do further research on them, and actually understand what went into the clinical trials and where are there some blind spots that need to be looked at. But I suspect, and we also have kind of a promise or maybe a hint that they may be distributed globally at affordable prices. But I think it's tough to be very optimistic in this climate. What you just discussed with Bill is a clear self-interest, a clear incentive for us to distribute vaccines rapidly across the world, which is to prevent the onslaught of new variants to come to our borders. So even if you didn't think healthcare, life-saving technologies was a human right that we as humans should have access to, then you would still want to vaccinate everybody in the world. And we're not doing it. And so you wonder, what does that mean for antiviral medicines and oxygen and other technologies that really improve clinical outcomes without maybe necessarily stemming as much transmission? So there's a reason to be pessimistic, but that really should galvanize us to be advocating for this all the more strongly. The last thing I'll say is related to what Bill just mentioned about testing. It's true that the UK is really at the forefront, at least has been at the forefront of finding these variants, describing them, and studying them. But right now, in rich countries across the world, there are something around 700, 800 tests done for every 100,000 persons every single day. The places where there's a lot of transmission has something like 10 to 15 tests done per 100,000 persons per day. What that means is that in sub-Saharan Africa, across Central and Southeast Asia, in low and middle income countries, there's not enough testing happening, which means that there are not enough people getting diagnosed, that there's not enough surveillance happening about what future variants may be coming. So that is reason for concern as well.
Amir, thank you very much. I think now we're going to try and take some of the questions that have been coming in, and I'm going to kind of put two of them together. We got a question from Nick about what do we think the coming holiday season and winter will look like here in the U.S. and will it be different in high vaccination states like Massachusetts and other parts of the country? And I think maybe we can pivot from that to talking about something that Bill brought up, which is, what does it mean when we go from the pandemic phase to the endemic phase? What does that look like? When will we know that it's happening? And I think we all assume that's a good thing, but what will it mean in our lives? So maybe I'm not sure who wants to tackle the forecast for the holidays. Do you want to try, Bill?
I'm the epidemiologist here. So yeah, the holidays are going to present opportunities for transmission. The consequences of that transmission will depend on the vaccine status of the folks who are infected as a result. I want to point out that we do have a rough indicator for how serious things might be, which comes in the form, again, of Florida, because you can compare the proportion of the over 65 population vaccinated in Florida when Delta came through, and then look at the hospitalizations, and you can get a rough sense that places which are that poorly vaccinated or worse can expect that things do have the potential to get that bad. Now, what that means is that there's quite a few communities in the US that are not vaccinated to that level. But they're mostly in relatively unpopulous areas around the Midwest, where actually you can already see cases starting to come up in North Dakota, just in an echo of what happened around this time last year or a little earlier. In a place like Massachusetts, on the other hand, we have a large amount of immunity from prior infection. We have a large amount of vaccination. And in case you hadn't noticed, cases are still plateauing rather than disappearing. And so I think that we have to be cognizant of the fact that there are still potentially relatively high consequence outcomes that could occur. And, Rick's in a better position to talk about this, and actually Rick and Amir, both of them, but we are still dealing with a backlog of care which comes about from having been fighting this pandemic bear for the last 2 years. And so relatively small shifts could have relatively outsized effects. And the last thing I want to say is we should not forget that we have other weapons in our arsenal, because we're even among vaccinated older folks, vaccinated nursing homes and so on, we should be aiming to avoid the virus being introduced to those places. I mean, we do this with respiratory viruses anyway, but rapid tests, carefully deployed, can help prevent the virus being introduced to high consequence networks. So I think I said this on NPR a few months ago, and it's still true. We're not out of the woods yet. Even if we are in a less woody part of the woods, we're not out of the woods yet.
All right. And then, Rick, do you have any thoughts about sort of what you're thinking things might look like as the holidays come upon us?
Yeah, I mean, I think we're all a little bit nervous about what's going to happen, particularly in some communities where there's COVID fatigue, where people are very tired of dealing with this, where they are eager, of course, for close connections with family members and getting together and trying to put this behind us. And so we're all very worried that that is exactly what this virus needs to circulate even more than it is now. I think, my feeling is that one way we could help prevent this from really becoming another wave in a way is to really emphasize testing. It should be much cheaper. It should be much more accessible, as it is in other countries in Europe, in the UK, for example, where people just literally get a stack of tests that they can use at no costs. These are not tests to pick up the tiniest amount of virus, but they pick up enough virus to know that if you're positive, you really should not be around anybody else. And if you're negative, the likelihood that you're going to infect somebody is really quite low. And if you try to combine that also with sort of being a little bit cautious in gathering, we might be able to prevent some of the problems that you would otherwise experience if large groups of people gather together. These tests, by the way, I know you asked us about pills recently. These tests are absolutely critical to know on whom to use some of these life-saving medications that two companies at least are in the late stage of development. Because if you want to use those pills, you have to use them very, very soon after the patient is known to be infected. And if we don't know that the patient is infected, it might just be too late. So I think a combination of keeping our guard up, as Bill says, testing. Many of us recommend that if you're going to go see a family member, that everybody in the gathering should test themselves maybe a couple times before they go visit each other. And of course, emphasizing vaccination is one way to avoid another onslaught.
I'd like to turn to a question about vaccine development. It comes from Kathleen, and she asks or puts forward that there are some concerns that there were not enough Black and brown children included in trials, especially on the pediatric use of the vaccines. And is there something that the group might be able to say about sort of how we know what we know about the vaccines in younger kids, and how to address this particular issue among some people?
So I don't know exactly what the numbers are for the demographics in the pediatric trial, but I know that there was a lot of effort put into recruitment of people from demographics that mirror this country into the various vaccine trials. And that's across all of the different companies. And so, for example, in the adult trial, 13% of this country recognizes themselves as Black or African American, and 10% of the people that were in the trials were that. There was also emphasis put on different comorbidities like diabetes, for example, or obesity. And I know when we think about comorbidities, at least for the children's trial, obesity was something that was very heavily put into it, because children who have obesity are more likely to have worse outcomes from COVID-19. And so I don't know what the demographics are, but I would weigh on the side of saying that they likely mirror what we see in this country when we think about ethnic diversity.
I mean, for example, the Pfizer 5 to 11-year-old trial, Scott, had, you could imagine it was not easy to try to get sufficient representation of the diversity of our country. About 6% of the children enrolled were Black. 6% defined themselves as multiracial, and there was about 20% that would categorize themselves as Latinx or Hispanic. So that was, the breakdown, if you will. And ultimately, we're talking here about a total of about 2,200 children. So we're not talking large numbers of any individual demographic other than white. The only reason I mention it, I'm not saying that this is a flaw as much as a reality that we need to explain to people who express that concern that it is indeed valid that there are not thousands of Black or brown children that were involved in these trials. It's just a reality. But it doesn't imply that there was an intent to avoid studying those children. It's just unfortunately one of the realities of clinical trials these days.
If I could add one really quick thing, and,
Sure.
and I really appreciate what Kazmiki and Rick said right there. I think there are analogs, certainly what I see with my patients with the question of getting vaccinated to begin with. We've had a long struggle to get people from Black and brown communities and racially diverse and economically diverse communities to enroll in clinical trials across the board, not just for these vaccines. And so it might take a lot on the research community of which I'm a part and which affords me enormous privilege to do more listening than talking and understand what can we do to right past wrongs that were made against a lot of these communities under the guise of our medical research infrastructure.
Thanks, Amir. I think we have time for one more question, and it comes from Helen, and it's a little bit related to the pandemic-endemic transition. And she asks, what's ahead for vaccination and the societal kind of response to COVID? Are we going to be in a situation where we're going to need vaccine boosters indefinitely and mask wearing and social distancing indefinitely, or will there come a time where we'll be able to change or relax some of those things? Bill, what's your crystal ball say?
Hang on, I just need to, let me get it out of the cupboard. It's a really valid question. And while it's true to say that we cannot be sure, there's a few things that I can suggest that it's important to bear in mind and it's important to look out for. The first thing is that, as I said, the nature of disease is going to be, in the endemic state, is going to depend on the epidemiological, meaning how much they transmit, and clinical, meaning how severe they are, characterizations of reinfections and breakthrough infections. If those remain relatively mild, then we might see probably seasonal peaks of disease like the other coronaviruses. There will continue to be people getting sick, and there will continue to be some people dying, and they will predominantly be older, but they will be far smaller in terms of numbers than we see at the moment. Essentially, this is the scenario in which we have vaccinated it into being the flu, or indeed even, not as severe as the flu. We're not really there yet. And we don't actually know exactly what those characteristics are going to look like, and we don't know exactly how long it's going to take. But we are going to be getting a lot more data on that, as I say, probably as we're coming through this winter. But as to the question of, are we going to be masking forever? Well, I certainly don't think so. I think that as some of the things that Rick was saying earlier about people's concerns and anxiety about it, as they start to fade away, as we begin to realize what has happened over the last few years, and the characterizations of these infections are less severe, people will start to become more relaxed. You can see already that there are lots of parts of the country in which people are not wearing masks. Unfortunately, the places where people are still wearing masks are probably the places where they need to do so least, the ones which are in the best position in terms of vaccination. But I think that the closing thing I want to say is that we should be thinking about the circumstances under which we would relax some of these things, because of the fact that if we don't think about them, then we're just saying, oh, we do this forever, we do this forever, we do this forever. And that's just a misleading impression to give. Having said that, I can guarantee you that next winter, there will be some people wearing masks in your community.
All right. Well, thank you very much for that. And I think that addresses the question quite well. And I think that brings us to the end of the question phase. And now we have the opportunity for each of you to make a closing remark or so. And I'd like to ask Kizzmekia to lead off. And if there's anything you'd like to say to kind of wrap up your part of this, and then we'll go around to the other panelists.
The main thing that I like to lead these conversations by saying is to remind everyone that we are not, as was said earlier, out of the woods yet. And getting out of the woods is going to take a very thoughtful and universal/global approach. And it is going to not just be the burden of us on this side of the research and the science and the epidemiology of it all, but also from the people. And so, and then also to leave people with the resources that they need. So vaccines.gov is constantly updating with all the information that you need around the vaccines, whether it be boosters or children, and to make sure that you follow each of us on your social media channels to keep updated with all the things, our opinions and otherwise around this pandemic. And yeah, to have a safe and fruitful holiday.
All right. I can get on board with that. Rick, what do you have to say to us?
I'll keep it brief. I think I just would like to reemphasize what everybody has said, which is there's so many reasons why we want vaccines and medications to be distributed equitably across the globe and not just in a few privileged countries. The reasons can be self-centered, they could be humanitarian, they could be ethical, or whatever you want to think about it. There's so much justification, and there should be no resistance to this. Resistance in this case is truly sort of shooting ourselves in the foot or elsewhere. And it's a shame that we're experiencing this again. And I hope that forums such as this one and all the other communications that people are doing are going to make people realize that we have to do better, not only for ourselves, but really because it is completely unfair that the accident of somebody's birth determines whether or not they will die of COVID or other horrible diseases.
Bill, what might you tell us?
Absolutely. Preach, Rick. And I echo Kizzmekia as well. Yes, you can follow us on our social media channels. I warn you, though, that I may interrupt mine sometimes to talk about Arsenal Football Club from my North London roots. But I want to say that there can be a certain amount of anxiety, fear, and even fatalism around this. I would like to dispel that. There are lots of things that you can do. The most important thing is getting vaccinated. There's all sorts of other low-lift interventions that you can take. To be honest, wearing a mask in the grocery store isn't that big a deal. And we can, if we put these things in place, the rapid tests, like Rick was saying, they hand them out on the beach or on trains in the UK. So people are able to keep track of their own infectiousness. And if they are infectious, have that information. Knowledge is power. And then I just want to hand over I want to close by commenting that it's so true that these are things that we're talking about locally, but there is a world out there. And Delta is doing horrible things to that world. And we should be doing everything we can to help it.
Thank you, Bill. And Amir, finally, what would you like to tell us?
I'm just so honored to be with you all and with this great group. And I second and third and fourth everything that's been said thus far. We've seen in past infectious diseases, tuberculosis used to affect everybody in the United States. We used to have malaria in the United States. HIV was in the headlines day in and day out in the 1980s. And then when we get out of the woods, it really depends on who we or who us is, because those diseases, those infections still run rampant, but in select communities, in racially ethnic minorities, in low and middle income countries around the world. And so our eyes really should be asking who are we? And if we're in a global community, then we can't leave any of these people out of our safety net.
Thanks. Thank you very much, Amir. And I'd like to thank all the panelists once again for what was a great discussion today. I hope that the audience found it as useful as I did. This event has been jointly presented by the Forum at the Harvard T.H. Chan School of Public Health and NPR. And thank you to the Cohn family for making this particular event possible. We'd like to thank you, all of you who watched, and for those of you who sent us questions. We weren't able to get to all of them, but we tried. So thanks very much and have a great day.